contribución de la braquiterapia en el escenario del trasplante hepático para colangiocarcinoma iliar. Conocemos que el protocolo propuesto es un componente de radioterapia externa, que eso es presumiblemente reproducible en diferentes centros, pero el componente de la braquiterapia que está incluido es más difícilmente reproducido en otros centros. En su experta opinión, ¿cuál es el verdadero contribuyente a los resultados de este componente de braquiterapia?
That's a very good question. I don't think the brachytherapy adds much, and I've never given the brachytherapy. I prefer to give the external beam boost. That was just what they did to begin with. I know it's very morbid. It's very difficult for most of us to do. So I think it's better to give a 45 gray initially, and then a boost to 60 gray. And that gets to be a very similar treatment with less side effects. I prefer that. Most of the transplant registries in the United States are okay with that, as well as we're okay with not using the brachytherapy.
Thank you very much.
Well, I think you could use SBRT, but I don't think it overcomes any of the limitations of treatment. I mean, it's certainly acceptable, but the only advantage of giving SBRT would be that it shortens the course of radiation. So that may be an important advantage. It's certainly well tolerated to give SBRT in 5 treatments, as long as the bowel can be spared. But you would need to give. No, I haven't given it, but I do think it's not toxic and it's a reasonable thing. And the main advantage, though, is going to be shortening the course of treatment.
Okay. ¿Alguien más? ¿Otra pregunta? Doctor Zamora, por favor.
Le quisiera hacer una pregunta. Felicidades por su presentación. ¿Alguna experiencia particular en el carcinoma de vesícula biliar incidental?
Yeah, we don't have enough cases to publish the results, but usually those patients have a radical surgical procedure after incidental finding. But if they're inoperable, I do think that the use of chemoradiation is an acceptable option at that time. But usually they're candidates for radical surgery, and that's more of a standard approach.
Thank you. Doctor Félix, ¿tiene otra pregunta? Por favor, por allá.
In the adjuvant setting of gallbladder cancer, when you have positive margins, if you don't have brachytherapy or intraoperative treatment, what is the dose, the recommended dose, when you only have external beam radiation therapy and maybe you don't have IGRT or COM-beam CT?
Okay. So if there's a positive margin, I think you have to be very careful about whether there's been a common bile duct resection or not. Because if there's a common bile duct resection and a jejunal reconstruction, the dose is clearly 50 gray. And usually that's the case. But if it's an incidental gallbladder that's been removed with a positive margin and there's no jejunal reconstruction, you should give 60 gray. So it's seems like a small difference, but you can't give 60 gray to that reconstruction safely. So even when there's a positive margin in the hilar cholangios, we stick with 50 gray because it's safe. Otherwise, you could cause bleeding in that reconstruction that would be very hard, possibly hard to deal with. So really you have to look carefully, and this is a mistake I think people make when they don't see a lot of these patients. You have to look carefully about what surgery has been done. Most of the time, Peter, wouldn't you do a common bile duct resection for someone with gallbladder cancer, or radical surgery? Yeah, yeah. So that's usually done. There's usually reconstruction there, so the answer is 50 gray.
¿Alguien más? ¿Otra pregunta que tengan el público, la audiencia? La doctora Lamanta, por favor.
can do in English. Thank you for coming. I think I have good memories during my stints at MD Anderson. Then I learned with you about all of that. But I would like to ask you about our daily life. That is más alto. Okay. I would like to ask you about the setting of unresectable because it's more often or real life, and I would like to hear your opinion about what cases do you recommend? Do you recommend to start with chemo and wait about the evolution of the disease and then do radiotherapy? Because I think we are a multidisciplinary team and we need to decide the best timing for radiotherapy. And what do you think about that? And what dose or technique do you recommend? Because you have here the summary of the results with 5 fractions with protons only, or well, SBRT, because you were talking about breast hold. But if we don't have, because we don't have here protons, in what settings or what are your recommendations about using more than 5 fractions so we can get lower BD but less toxicity?
So I think for unresectable cancers, it's a different answer depending on whether we're talking about intrahepatic or hilar. So which one first? Intrahepatic. Okay, so for intrahepatic, the standard of care is to start with chemotherapy. We know that there's a 70% distant metastatic failure rate. Many of those patients can respond and may stay on chemotherapy longer because they're responding. There are now emerging other chemotherapeutic options. So the challenges of treating these patients have to do with the liver tolerance, and you don't necessarily need to have proton therapy. You don't necessarily need to use SBRT, but you can get over those the limitations of that are in place by giving these large doses per fraction by giving more fractions. So if you give 25 fractions, 3 gray per fraction, that's almost always going to be with intolerance of the liver and the GI tract. But you can have simple solutions, but you need a solution for breathing motion. So a compression device will work fine. We use breath hold, but it takes resources and time. Those are some simple solutions. So you just have to be careful of where the duodenum is, where the stomach is, where the colon is. Immobilize the liver the best that you can, and give more fractions. In the United States, we're in, our radiation oncologists are stuck in this paradigm of giving 5 fractions, but you can use the same technique and give more fractions to achieve this effect. Now, for hilar cholangiocarcinoma, I think that it's only the anecdotal patients that's going to benefit from that, but it's actually easier to give high doses of radiation with even fewer fractions because the duodenum is the only thing you have to worry about sparing.
Okay.
Only, do you use a fiducial placement in the intrahepatic, or if you are able to recognize in IGRT convincity, you do consider it is enough?
Okay, so it's I don't always, I skip that step if there isn't a fiducial in place, if it's in the right lobe and it's not near the GI tract, I skip that step and I set up to the liver shape. But if it's in the dome, there's a lot of motion at the dome, so you need to have a fiducial at the dome, or you need to add some extra margin at the dome. And the left lobe moves a lot from day to day too, so you really should have fiducials for that. A lot of times these patients have had surgical procedures. There are clips that can be used as fiducials. We always look, that's the first thing we do is look to see what kind of metallic devices they have inside. And if we can skip that, we do, but we also have the opportunity, if we're going to place a fiducial, to get another biopsy for genomic profiling in the United States is more common. So yeah, we try to skip that step, but I'd say probably less than half of the time we use fiducials that we have to place.
Okay.
¿Alguien más? ¿Una pregunta? I have a question. Doctor,
¿En español o en inglés, perdón?
Español.
Bueno, a lo mejor no me conocen porque no es de esta área, pero estoy en endoscopía. Yo hago más que nada lo que es pancreatobiliar, las CEPRES, las colangioscopías y el ultrasonido endoscópico. Y nomás quería mencionar que para aquellos que no lo sepan, aquí tenemos la posibilidad de hacer la biopsia de colangiocarcinomas iliares o en otros sitios también, con ultrasonido endoscópico con muchísima precisión, y en el mismo procedimiento, con la misma aguja, podemos poner fiduciales. Entonces tenemos ese recurso aquí en el hospital. Quizá no se ha conocido mucho, pero eso lo podemos hacer aquí.
Yeah, we most commonly place fiducials with under endoscopy, just because it's easier to get those appointments. But that's mainly for pancreatic cancer too, so it's a very important contribution. And we always try to get a biopsy at the same time if possible.
No, sí, le felicito porque sí es verdad que es algo que se está haciendo ya en México, no es algo que no exista, y hay varios centros, pero sí quería por eso hacerle la pregunta de en qué situaciones se pueden omitir o en cuáles no, porque ese es el secreto. Y lo que él ha contestado del domo es muy interesante porque la localización de los tumores a veces para radioterapia sí es importante.
¿Alguna otra pregunta de la audiencia?
Yo tengo una última.
Ok, adelante.
In English, I would like to hear your experience with the new drugs, therapy drugs, and SBRT and the concomitant approach. If you have any adverse events or whatever, because usually the medical oncologists knew how to manage the new drugs, but we don't have a lot of experience about that.
Yeah, so the only radiosensitizer that we're using with these high ablative doses is capecitabine, which is basically the same as IV5FU. The only radiosensitizer that really know works. But usually when you're treating any of these biliary cancers and there's no GI tract in the field, it doesn't have to necessarily interrupt the chemotherapy the patient is receiving. So So a lot of times we will continue or take only a very short break if there's a desire to give radiation during the course of chemotherapy. However, usually we're using chemoradiation as a way of consolidating and getting off of chemotherapy. And as Ghassan mentioned before, there's an emerging strategy that still requires a lot of work of giving these ablative doses and hoping that we're achieving basically an in situ vaccine, and then following that with immunotherapies. I mean, we basically only have very limited information now. One randomized trial in lung cancer that I think is a good starting point, but it's something to keep focusing on for the future, because the big risk in these patients is distant metastatic failure, pancreatic and intrahepatic cholangiocarcinomas.
Do you use not concomitant bevacizumab?
No, we did those trials over 15 years ago in rectal cancer and pancreatic cancer, and there was no improvement. So we did a phase 2 trial in RTOG, and there was no improvement in pancreatic cancer. So basically after that, Avastin was abandoned as a radiosensitizer.
Okay. Doctor, the last one. ¿Nadie más? Last question. Do you use a scale to refuse or accept a patient to treatment with radiation therapy?
Well, very few contraindications. Even in retreatment settings, we can treat them. It has to be done with extreme care. We just put together an issue and seminars of radiation oncology about that topic of reirradiation that'll be coming back out in the next couple of months. But basically, you know, the only thing that makes it more challenging for us is to give a definitive dose is if they can't really participate in holding their breath with deep inspiration, breath hold. It makes it more challenging, but we still do our best. But there's really not, these stereotactic treatments are extremely well tolerated. So we don't really have much in the way of contraindications. We know that if the GI tract is nearby and they're on anticoagulation, that they're at a little bit higher risk of bleeding, around 8%, but it's been manageable without surgical procedures. We don't even have one patient that's needed a surgical procedure for the bleeding. So we had one that Peter and I share who had a fistula that formed into the duodenum that was unclear. That was the only severe event we've had. But I think that was possibly tumor-related. So it's been fairly well tolerated, and is, you know, it makes it more difficult, but they'd still be candidates if they were older and couldn't hold their breath.
Okay, thank you much. Thank you very much to Dr. Christopher Crane for joining us and participate with this great talk. Gracias.